When a patient loses the ability to maintain adequate gas exchange on their own, physiological collapse is imminent. Intervention becomes mandatory under 3 strict clinical conditions: acute respiratory failure, hypoxemia, where blood oxygen levels plummet, and hypercapnia, a dangerous buildup of carbon dioxide in the bloodstream. This illustration of a standard ventilator highlights the complex interface clinicians face when taking control of an airway: a dense array of monitors, parameters, and a maze of pneumatic tubing. While the ventilator maintains oxygenation, it does not resolve the underlying pathology, and excessive mechanical force can cause secondary trauma. To manage this intimidating interface, we must reconstruct a ventilatory strategy from first principles. That process starts by defining the 4 core titratable parameters of a single mechanical breath. Next, we examine how those parameters are deployed across 3 distinct operational modes to match the patient's own physical effort. Finally, we translate the real-time waveform telemetry flowing across the monitor back into actual lung physiology. The ventilator serves as a dashboard for precise physiological control, functioning as a predictable tool once the foundational settings, modes, and monitoring variables are understood. Clinicians control a very specific set of variables to construct an artificial breath, organized by the memory tool TRAP. The T stands for tidal volume. This diagram shows tidal volume as the exact physical displacement of air delivered to the lungs in a single breath. To prevent lung overdistension, the adult clinical range is tightly calibrated to 6 to 8 milliliters per kilogram of the patient's ideal body weight. The R represents respiratory rate. This dictates the mandatory frequency of breaths the machine will deliver. For a standard adult, this rate is typically set between 12 and 20 breaths per minute. A stands for airway pressure, clinically referred to as PEEP, or positive end expiration pressure. This animation illustrates the mechanics of PEEP at the microscopic level. As the patient exhales and the alveolar sac attempts to collapse, a continuous influx of positive pressure acts as a physical stent, holding the failing alveoli open. The standard clinical range for this resting pressure is 5 to 15 centimeters of water, titrated to the severity of the patient's lung disease. Finally, the P stands for percentage of oxygen, known clinically as FiO₂, or the fraction of inspired oxygen. Room air sits at 21%, but the ventilator can increase this concentration all the way up to 100% pure oxygen. This fraction is dynamically adjusted to ensure the patient's peripheral oxygen saturation, or SpO2, remains safely above 92%. By systematically manipulating these 4 TRAP parameters, clinicians construct a highly specific, artificial breath precisely calibrated to stabilize a patient's unique physiological deficit. Once those parameters are set, the machine must interact with the patient. This requires a threshold known as trigger sensitivity. Trigger sensitivity is the exact point where the ventilator detects a patient's physical diaphragm effort, signaling an attempt to initiate a breath. This diagram highlights the common ventilator modes. These are the control algorithms that dictate exactly how the machine responds once a patient triggers it. This graph visualizes the first of these algorithms, assist control, or AC, which provides full ventilatory support. You can see a steady rhythm of mandatory machine breaths as identical square waves. When the patient makes a spontaneous effort, represented by that small dip, the machine assists them by delivering another full-sized wave. The primary clinical risk here is hyperventilation. The machine guarantees the delivery of the full mandatory tidal volume for every single breath, regardless of how many extra breaths the patient decides to trigger. The graph now transitions to SIMV, or Synchronized Intermittent Mandatory Ventilation. The identical mandatory machine breaths space out, creating gaps where smaller, uneven waves appear. This represents partial support. The machine guarantees a baseline set of mandatory breaths, but if the patient triggers a breath in between those cycles, they pull only their own unassisted tidal volume based on their muscular strength. Finally, the graph shifts to CPAP, or Continuous Positive Airway Pressure. The large machine breaths disappear entirely, leaving only a slightly elevated baseline with varying patient-generated waves rolling along it. In CPAP mode, the machine provides 0 mandatory breaths. It strictly maintains the PEEP baseline to keep the airway open, leaving the respiratory rate and tidal volume entirely up to the patient. Ventilator modes are a negotiation of effort. They dictate the precise division of labor between the patient's recovering diaphragm and the machine's pneumatic drive. Translating these settings and modes into actual patient outcomes requires constant real-time monitoring. This display panel details the 3 primary waveforms found on a ventilator screen: pressure, flow, and volume plotted over time. Clinicians evaluate a single breath cycle by identifying the synchronized inflection points that occur across all 3 stacked graphs simultaneously. These waveforms provide a direct window into the strength of the patient's spontaneous breathing effort, showing exactly how hard they pull against the circuit. The volume waveform is particularly diagnostic. If the inhaled volume line fails to return to 0 during exhalation, it definitively identifies a hidden air leak in the closed circuit. Similarly, if the flow waveform does not return to baseline before the next breath begins, it alerts clinicians to auto-PEEP, a dangerous state of incomplete exhalation that traps pressure in the lungs. By comparing the shape and timing of the graphs, practitioners can instantly detect patient ventilator asynchrony, pinpointing moments where the machine's delivery cycle and the patient's muscular contractions are fighting each other. These waveforms serve as real-time mechanical diagnostics, translating hidden lung compliance into actionable visual data. The inherent violence of forcing pressurized gas into diseased lungs carries severe iatrogenic risks, as listed in this complications panel. The application of inappropriately high pressure settings can cause barotrauma, physically rupturing delicate lung tissue and inducing a pneumothorax. Prolonged exposure to extremely high FiO₂ levels introduces the risk of oxygen toxicity, which degrades alveolar cellular structure over time. The artificial airway itself bypasses the body's natural defenses, creating a direct pathway for ventilator-associated pneumonia, or VAP. To mitigate these complications, the bedside practitioner must execute a continuous clinical operational loop. This requires aggressively monitoring vital signs, drawing arterial blood gases, and verifying oxygen saturation independent of the machine's internal telemetry. It involves the mandatory execution of the VAP bundle, ensuring adequate circuit humidification, and performing necessary airway suctioning to clear secretions. The bedside clinicians must prioritize the patient's physical presentation over the numerical data on the monitor. Mechanical ventilation is never meant to be indefinite support. The proactive objective is to wean the patient down to extubation as early as physiologically possible. Mastering the ventilator means perfectly balancing life-sustaining mechanical support against the ticking clock of clinical complications. It requires the practitioner to apply the right settings at the right time, while never losing sight of the human being